And thank you. And I share your sentiment, Emma, regarding being the joint awardee for this fellowship for the first time between nurses, and giving me this opportunity to share my experience of what I did with my scholarship. So some might think it's a very bizarre choice of slide selection, but there is a method in the madness. When I was in Canada, as part of the fellowship, they did a little art project for patients who were suffering from delirium, and their way of expression of how they felt when they did experience it and post episode of delirium. And some of the pictures that came out were very, very bizarre. There were snakes in pillowcases. There were water pools on beds, and that is why we see the reaction the patients have when they do get delirium. They don't want to go back into their bed, and one interesting one was huge orange fireballs. And then a few days later, when they were talking to this lady, she kept throwing glasses of water towards everybody who walked towards her. But then now we understand that what she saw when people approached her were these fireballs, and she didn't know how to cope with it, so she kept throwing water. So this was my little way of us experiencing what they're experiencing, and maybe know how they feel and try and help them and maybe help this situation a bit better. The objectives of this particular presentation would be just to see what delirium is in cardiac surgery, my Ionescu scholarship trip, and my PhD journey so far. Nationally, the role of a nurse practitioner is so different in this country, so I thought I'll briefly go over what I actually do as a day job. So we run a pre-admission clinic where we assess patients' fitness for cardiac surgery, and we try and optimize them before they actually come in for their surgery. They get admitted the day before the operation, and we tie any loose ends if there are any. After that, we're ward-based practitioners. We're 4 of us. At the moment, just 3 for sickness reasons. We manage and monitor their clinical progress till they are ready to go home, get discharged. We refer them and liaise with different specialties if required. If not, they're discharged home. We refer them to rehabilitation and then follow up if there is a wound problem or any other clinical issues which need looked into. The ethos of this whole practitioner role is to make the patient journey as smooth as possible as they have cardiac surgery. What happened in 2013 is I have been doing cardiac surgery, been a nurse in cardiac surgery for the last 22 years in 2 different continents in India, and then I spent 5 years in London, and then now I'm settled in Scotland. Even as a nursing student, you would hear anecdotally episodes of patient getting post-pump psychosis. You hear people mention a patient is a bit muddled, confused. There was never the word delirium ever used. And when I reached Scotland, I remember them using the word post-pump head, which now looking back, I realize it is pump head. And we all know and talk about it so often. So there was a data presented, that's the Tomcat data, which is St. Thomas's Catheter Lab database, which we use to find out complications and our patient progress. And if you see the light pink, the purple, which shows bleeding and the different complication, death, infection in light blue, stroke in yellow, and you see arrhythmias, which is about 30% of our patients will get arrhythmias, which is a significant number, and that's in green. But the highest number, which is about 45%, is delirium. But we still don't talk about it. We put it down as one of the complications patient had, or something that delayed patients' discharge, or made their inter-hospital stay very, very choppy. But it seems to be such a minuscule and insignificant part. But actually, if you look at it, it's quite a big portion of the patient stay in our cardiac surgery hospital. So when I applied for the Ionescu scholarship, my idea was to understand this better, see get a better appreciation of what actually happens when patients do get delirium, because we fail very badly in looking after patients and know what to do when patients do have delirium, and see what other centers do. But looking around the UK, there wasn't much going on at that point. So my idea was to go and maybe learn from the delirium experts and then see what happens outside the UK. So my first stop was going to the European Delirium Society meeting, which was in London in 2015, end of last year. And there was a better confirmation of how they look at delirium, because that's their expertise. So according to the Diagnostic and Statistical Manual of Psychiatry, delirium is an acute onset syndrome with disturbance in attention, awareness, and cognition. There are three types of delirium, which probably was aware of but didn't really know any better. The most commonly that you see one is the hyperactive one, where the patient's throwing things, pulling things, not with generally doing what is expected post-operative day 1 or 2. The second one is a hypoactive delirium, which is the most missed form of delirium. And the third one is a mixed delirium, which is probably the most common, because the patients go through the phase of hyperactive, hypoactive, and then again, probably again, hyperactive. What else did I learn when I went to this meeting? So they reassured us, saying that delirium is common, especially where there is vulnerability. Now, if you see more and more our patients, they're older, frailer. That's why the incidence of delirium is getting more higher. The interaction between vulnerability and precipitant is key to understanding the epidemiology and the pathophysiology of delirium. Again, that's reassuring to know that if you're aware that the patient is vulnerable, if you know what the precipitating factors are, you might be able to reduce the incidence of delirium. And the last one is the pathophysiology is poorly understood, but opportunities are many. And again, that helped to know that you could do something maybe to change the trend and to make the situation better. Excuse me. They then presented the data from their point of view about post-operative delirium. And if you see, interestingly, cardiac delirium post-operatively is the highest number. But again, going back to the first slide, we don't talk about it. It is such a high complication, and we still don't mention it. So some of the messages that I came back from that conference is post-operative delirium. There are some preoperative factors that you need to know about, and that's age. Our patients come with multiple comorbidities. Quite a big patient group are smokers. We have deranged electrolytes and need to be aware of. All these are the precipitating factors which could cause patients going into an episode of delirium post-operatively. Next is, what does delirium actually do to your patients? Morbidity, pressure sores, they fall, there's functional decline. It increases the rate of staying in the hospital, and even if they're discharged from the hospital, they would stay in a nursing home or a care home till they're ready to go home. And these are patients who are probably quite fit and independent before they came for surgery. Mortality, the short-term and long-term mortality is quite high, and of course it increases the financial cost by their length of stay increasing almost 4 times compared to a straightforward discharge from hospital. This was an interesting study done by Szynski in 2012, which was published in the New England Journal of Medicine, where they looked at 225 patients having cardiac surgery, both CABG and valve, and they saw that, which is a post-operative mini mental state examination and CAM, 46%, which again tallies with the number that we saw in our center of patients develop post-operative delirium. But the good news was, when they followed them up 6 months and then 12 months after, it was almost negligent. They were back to their basic functional cognitive state. This was I just wanted to briefly talk about it because, as I was saying, we don't talk about delirium. We don't even understand what the legality is. There was this case in 2013 where the coroner found that the patient who developed pulmonary embolism and pneumonia post-op cardiac surgery, it was straightforward that these complications caused the death of the patient, but the coroner felt that the delirium was provoked by surgery and trauma. It was also held that Mrs. L had endured 10 days of discomfort prior to surgery, which made her less able to resist the effects of delirium. And the verdict was of misadventure. So we cannot take this lightly anymore. It is an important complication. It has legal implications too. So I traveled to Canada. I went to a center in Toronto, which is called the Peter Monk Cardiac Center. And the nerd in me wanted to know how good this institute is, and it is. It's first in many, many areas. The first clinical use of heparin, use of external pacemaker, hypothermia during cardiac surgery, stentless aortic valve replacement, and the list goes on and on. So quite an exciting center to go to. And they're a very, very passionate group of people, multidisciplinary team, nursing, physios, physicians, even the surgeons, surprisingly, were very interested in this area. They class delirium as acute brain failure. So for them, if you class AKI, acute kidney injury, as an important complication, liver deranged as a big complication, so why not look at brain failure, which is delirium, as an important complication and do something about it? So it was a great center to go to. I'll come to the take-home messages. So they not only have a resourceful group of people, but they also have financial resources to be able to do what they plan or what they envision. And this is, I wish I could take a video of this, but with copyright and everything else, I couldn't do that. So this is where the intensive care unit is, just adjacent to the board which says the conservatory. And the patients, every afternoon, they're wheeled out, and it's this open space, this atrium where they get skylight. There's a piano, they can do art, they do music, and they can hang out with their relatives. They come with drains. I even saw a patient with an intra-aortic balloon pump walking. So the idea is mobilize patients. I had to do a double take and almost was tempted to take a picture, but I would be in a Canadian prison, didn't want that. And it was so inspiring. So even if you're having a dull day, you're in pain, a bit of discomfort, you get your analgesia, and then you move out to this, and that is a natural pain relief, and you're in your natural environment. And I thought this was probably their key to patients getting low incidence of delirium. Yeah. Now this is something I clicked. They see delirium as everybody's business. Everyone is responsible, and they talk about it as if you have to look after this business quite important. So if you see, they call themselves the partners of care, if you see the various circles which are at the bottom, so help with eyesight and hearing. So when they take them to this little atrium that I was talking about, the first thing the nurses, when they wheel them out, obviously make sure their hearing aid is in, their glasses are in, the basic things that we need to do for our patients, even if they are in a box, in a side room or an intensive care unit, reorient them to where they are. Help them with activities. So their mobility starts with being wheeled there, and see if they can walk up to, there are various trees, and the trees are various colored pots, and see which plant they can reach every passing day. So the patients find themselves achieving something every day. Help them rest and sleep. So they know 2 to 4 is the time when they go to these sessions, the art therapy sessions or whatever sessions planned for them that day. So the timing is so crucial. They tell them, so morning we're going to have breakfast and the physiotherapy, rest period, art session, yoga. They have all sorts of activities planned there. Healthy eating, as I was talking about the electrolyte imbalances which causes delirium, so help with healthy eating and mental stimulation, all these activities which are non-pharmacological but so effective. As you pointed out, Emma, this is quite a cultural thing if anyone's been to Canada. So the first meeting, 9 o'clock on a Monday morning, was in Starbucks, and the afternoon session was in Tim Hortons, which is their coffee haven. And I thought almost this was skiving after getting a scholarship, go to and sit and have coffees, but that is where business happens, that's where work happens, which I quickly realized. So when they said the next meeting is so-and-so cafe, you know exactly, you tick on the box where the next business meeting was. Yeah, so big coffee culture. So take-home message from there was, this is this 8-point thing and components of delirium care. If you look at it, it's clockwise. So if you care about the prevention, treat all the precipitating causes, and optimize conditions for the brain, you probably wouldn't have to go through the whole chain, the whole cycle. So the main key was prevention of, if you knew patients, so in my case, I suppose when patients come to the pre-admission clinic, we identify patients with substance abuse, alcoholics, and with social issues, and we start identifying these people and setting things in place before they actually come to the hospital. So the withdrawal programs set. So this is something which we did probably, but which I brought back now, is an established program. So if the withdrawal program is well taken care of, the incidence of delirium is noted to be much less. If there atrial fibrillation, one of the causes, so if you identify patients, so what they do is 2 weeks of amiodarone or antiarrhythmic is started 2 weeks before they actually come to the hospital. So by the time they have come, they've almost deleted one of the problems that could cause their postoperative delirium. The 4 strong do recommendations that they always preach about in that center is a medical evaluation to identify and manage contributors of delirium. They have fantastic data sets, and as I said, everyone is responsible. So the medical team look after it as much as the nursing, the physiotherapist, and the other allied health professionals. Effective pain management and fantastic education programs. That's one of the things which I've definitely brought back is an e-learning that they do. So all Band 5 and Band 6 nurses, they have different levels of delirium care, and as you were talking about it, Chrissy, something which part of the induction program, the awareness which starts at a very basic level. The strong do not recommendations were avoid any deliriogenic drugs, and do not, polypharmacy is probably one of the biggest problems which causes delirium. Do not start anticholinesterases, do not use benzos as first line of treatment, and avoid antipsychotics in hypoactive delirium, which I said was probably one of the most missed form of delirium. I saw this poster by Professor Bernard Isaac, who's known to be the father of geriatric medicine. He said the heart is a pump, and when it fails, it's a failed pump. The brain is a mystery, and when it fails, it remains a mystery. And it must be very sad for the patient to know that nobody understands what's going on with them. You're trying to do what you think is right, but it's not right for the patient. So it's almost you're treating what yourself rather than the patient. I like this picture because I had a meeting organized with one of the surgeons it was a last minute meeting organized, and she was on call, and just my luck, there was an aortic dissection and she had to go to theater. So I walked a few miles just down the road, so inappropriately dressed, to this caves. And it was dark, I didn't know where I was going, and I walked and walked and walked, and the other side was this beautiful, beautiful beach, and I thought, this is how I want my PhD journey to be. It feels really tough just now, but at the end of it, hopefully, it makes a difference. So thank you, Ionescu, and thank you.